Well, hello and welcome to Pharmacological Interventions on this Teaching Tuesday of BFRB Awareness Week 2022. I'm Jen Monteleone, Interim Executive Director at the TLC Foundation for Body-Focused Repetitive Behaviors. Some quick housekeeping items before we get started. This is an educational webinar offered in a safe and welcoming environment for everyone attending today. Questions for our guests should be asked through the Q&A feature, and your questions will be asked during and throughout the webinar. If you have any tech challenges during the webinar, please use the chat box to message one of our TLC staff members, and we will be happy to assist you. Our guests today are experts in the field of body-focused repetitive behaviors, Dr. Jon Grant and Dr. Darin Dougherty. They're here to provide some updates as well as answer your questions related to medications and BFRBs. Please help me welcome Dr. Jon Grant and Dr. Darin Dougherty. Hello.
Hello. Good
Thank
to see
you both.
you.
Good to see you too. Thank you so much for being here today. I'm going to go off camera and I will help with question and answers. Here we go.
Well, let me first say how excited we both are. I'll speak for Darin on this one because we've talked about how excited we both are to be here to give some insight into the medication piece. You know, that medications have been used for 30 plus years now for BFRBs, and we've started to learn a bit more over time. You may still, though, find that as we answer questions that there's still more questions than answers. But we're hoping that at least in some people that using medication, perhaps in combination with behavior therapy, may help them a bit more to help control their behavior.
Great, and I'm Darin Dougherty, happy to be here as well. Good to see you, Dr. Grant. So we thought today what we would do is be available for questions. Rather than reviewing, the laundry list of medications and the like, we thought we would make this more interactive. So please feel free to put your questions in the Q&A. Those will probably direct us to talk about different classes of medications and the like. So we look forward to getting some questions.
So attendees, if you want to go ahead and put any of your questions related to medications in the Q&A, please do that now. And we will open the floor for questions in just a moment. Okay, thank you all so much. Are you ready, Dr. Grant and Dr. Dougherty?
We're
Yes.
ready to go. Yes.
All right, the first question is, what are your thoughts on NAC specifically related to TRIC?
Well, if I can start.
Yeah, Dr. Grant's done the NAC study, so we'll let him answer this.
We started doing those studies probably over 15 years ago now, and I still think it's it makes sense from a mechanistic standpoint, how it works in the brain, and it has shown benefit in our study in adults compared to placebo. I think a couple things that I would say about the NAC. So in our study from 2009, we used a total of 2,400 milligrams of NAC, which was about 4 capsules. I will say in clinical practice, I tend to sort of maybe even go to 3,000 or even 3,600. It's safe at those doses. But I think the confounder in all of the mix, and many of you probably know this, that when you prescribe something like an antidepressant, the pharmaceutical companies make sure it's the same antidepressant that I prescribe in Chicago will be the same antidepressant that Darin prescribes in Boston, the same quality, made by the same companies. NAC varies most likely in quality across all of these sort of nutraceuticals, these companies. And so I think quality control has been a question that when people say, oh, I didn't get any response, maybe it didn't work for them. And that's completely a legitimate comment, but is it the actual brand? Maybe as well. So we just don't know. That's a difficulty with these the products that are not FDA monitored.
Next question. Any update, and I'm not sure if I'm saying this correctly, but memantine,
Memantine, yep.
any update on the memantine study?
So thank you. So that was a study that we've been doing here at the University of Chicago, and thanks to everyone who participated in that. That was a bit of a new type of study. We included both people with hair pulling and skin picking in the same study. And it was the largest medication study done to date, just about 100 folks. So that was wonderful. And when we've done the analysis, it's not out in published form yet. It's being reviewed by a journal and all of that, which is part of the peer review process. But our data analysis showed that it was significantly better than folks who got the placebo. And about 2/3 of people with that drug, which is, as many of you probably know, an old generic drug now that is actually FDA approved for Alzheimer's dementia. And the reason that we used it, one, it's been used in OCD for 15 or 20 years, I think, as an add-on to an antidepressant. In this study, people were taking it on its own unless they were on a medication already. And the way it works in the brain, it seems as if the data shows that it may help with what we would call improvement of cognitive flexibility, unsticking people. And so we thought, based on some of the encouraging data from the OCD world, we could use it in BFRBs. And I'm very happy that it seemed to help people without really much of any side effects for the most part. A little upset tummy or a little dizziness in a small percentage of people. So.
Yeah, it's generally well tolerated. You note that the target audience for this drug, target population, are usually frail older people with dementia. So it's usually pretty well tolerated. And as Dr. Grant said, there's more data for OCD suggesting that it's effective, and we suspect that it is for body focused repetitive behaviors as well.
Thank you. All right, here's the next question. Is there anything hopeful on the horizon in terms of medications? For those who have tried NAC, Prozac, Zoloft with no benefit, ? Is there anything else hopeful on the horizon in terms of medications for BFRBs?
Well, not included in the meds that were mentioned there are ones that are already available. And I'll let Dr. Grant talk about any other that are on the horizon. But there's data to suggest that sometimes augmenting with an atypical antipsychotic at low doses, doses way lower than we're using to treat psychosis. We're not treating psychosis with these agents, but with the low dose atypical antipsychotic, there's data to suggest that could be helpful. I'll let Dr. Grant comment on any other stuff in the pipeline, if any.
I think maybe once the memantine has been peer reviewed and published, that may be an option for people to read through all of that and take it to their primary doctors or psychiatrists to see if that may be one of the options that could be beneficial. We have started a study as well. And as you know, most studies that you start, sometimes they just don't pan out. That's very common, but we are looking at a cannabidiol product, not THC, but the cannabidiol product that one would find in cannabinoids. So it doesn't have the hallucinogenic effects. And we're seeing if maybe that might help, but that's going to be kind of down the road before we get that done and understood. I don't know of any other ongoing studies. As you know, the BFRB community of researchers is small. And so we wish that everybody was kind of trying to figure out things, but it's a labor of love, and it takes a while and all of that. So sort of the products of science are churned out fairly slowly.
Yeah, and I will add, if memantine does look like a promising treatment, one advantage there is what Dr. Grant referred to earlier. We know the memantine is going to be the same wherever you take it. as opposed to the N-acetylcysteine. And I pair those two together because they both affect a specific neurotransmitter, glutamate. So it may be that memantine is a cleaner way to address the glutamate system than NAC if we get there.
We have several newcomers to our community on the call today, which is wonderful. But many of them are asking for us new to the community, what are the list of medications in general that might be helpful to treat body-focused repetitive behaviors?
I can start, and then Dr. Grant, you can fill in. Really, I put them in 3 buckets as to what neurotransmitter they affect. So the serotonin drugs are the SSRIs, the Prozacs and Zolofts that we heard about, but also clomipramine. Interestingly, for the SSRIs first, there have been trials that have shown that it's effective for bodily focused repetitive behaviors, and then also trials that failed to show any benefit. If there's been a meta-analysis done, and it looks like it's about a wash. So there's not strong data to suggest that SSRIs are helpful for BFRBs. My guess is that it's helpful in some, but not in others, and that's why those trials have been, less than definitive as a whole. Clomipramine, however, in the meta-analyses, it's an old tricyclic antidepressant that works predominantly via serotonin. That stood out as having efficacy. The next bucket is dopamine, and predominantly that's the atypical antipsychotics that I talked about. How to use them is interesting. Usually in other disorders, we add them to an SSRI or an SNRI. And that's how some of the trials have been done in bodily focused repetitive behaviors, but there's also a few trials of using them alone, which we usually don't do in OCD, for example. So we're still learning about those, but those dopamine agents might be effective. And then lastly is glutamate, and that's the NAC and the memantine we talked about. There's another drug in that class that's been studied for OCD, but not in BFRBs, to my knowledge, is Riluzole. It's an old ALS drug. So that's kind of the laundry list. I'll let Dr. Grant comment on any component of the laundry list he'd like to.
I would just add for people, as we talk about these things, just as a little bit of context maybe too, Darin is spot on in terms of those 3 categories. Some people will read about a bunch of drugs that may work, and forgive me for people who already know this, but in science, there are things called case reports where people just write about, oh, somebody got better trying X. And then there are kind of these things called open label, where everybody also gets the drug. Everybody knows they're getting the drug. There's no fake pill or placebo. And those are also out there for BFRBs. And then there's really the highest standard of science when you compare a drug against a placebo. I, as the investigator, I don't get to know what the person's on, and they don't get to know what they're on. And then you track whether they improve. And so Darin's comments really are focused on that highest level of science. But I would just caution, sometimes people will read about all sorts of things that have been used, and God love them, clinicians are trying a lot of things and they'll write it up, but it may not be that at that highest level of science. It doesn't mean it's not good. It just means it really still needs a more rigorous study to really find out, does it survive, that highest level? And so often when you go online, you see all these little, snippets about, I tried X, it helped. And I find all of that useful information. It's just not the most rigorous scientific information. So,
yeah, that's important. Those open label and case studies are important for potentially designing the gold standard trial, but they're not gold standard trials.
Thank you. Here's another question related to skin picking. What medications have you found to be the most helpful to stop the incessant urge to pick at imperfections on my skin, namely my face?
So I'll start with this one, I guess. And what I would say is skin picking, in my opinion, is always there's a couple extra complications to it. So first, we always want to know if skin picking is its own independent problem, or if it's related somehow to body dysmorphic disorder.
Mhm.
And the reason for that is if I'm picking really to improve my appearance, that my primary issue is I'm obsessed with feeling ugly or unattractive, or, in some cases, people will describe themselves as hideous. And it's very, it can be very demoralizing for people. In those cases, an SSRI antidepressant or clomipramine might be wonderful, and it may help, in any number of ways. If it's not related to that appearance obsession, then we fall back on what Darin has already mentioned, which are some of the medications that we would use for hair pulling have shown benefit for skin picking as well. And so I think that, and I will say just as a bit of an extra element, we did show in one study, so years ago, Gary Christensen, God love him, one of the pioneers of BFRBs, had done a study looking at this drug naltrexone.
Oh, yeah.
And it's a FDA approved for the treatment of, say, alcoholism and opiate addiction. And you think, what the heck, what's going on there? And he used it for hair pulling, and in one of those kind of high double-blind designs with a placebo. And he found that it kind of helped, maybe kind of. It kind of was equivocal, let's say. So we went back a few years later and I did it again against a placebo, and it didn't help compared to placebo. But people who had BFRBs, in my, the data showed this, and had a first-degree family relative with, say, alcoholism or some other addiction, found that that urge to pick or pull was substantially decreased by even using a drug like that, which on its face you would say, but it didn't work. It didn't work for everybody with a BFRB, but it seemed to work quite well for those who had, say, a family history of addiction. So that just complicates our sort of the story even further.
Yeah, so I would add that bucket. I mentioned serotonin, dopamine, glutamate. I would add potentially opioid based on the naltrexone data as maybe a fourth bucket in terms of neurotransmitters.
Thank you. Another question, any luck with Dupixent for folks with BFRBs?
I'm not familiar with any research of Dupixent.
No, I don't think anybody, I don't see, I can, sometimes if you go, there's a website called clinicaltrials.gov, and you can find ongoing trials around the country for any number of indications from, diabetes to skin picking. And I check that routinely, and I've not seen any studies looking at Dupixent. So.
Okay. What is the current research on medications for ADHD and BFRBs?
Not much. It's interesting. Usually, but not always, ADHD is treated with stimulants. And that's methylphenidate, which you guys probably know as Ritalin and all of its derivatives, or mixed amphetamine salts, which you guys probably know as Adderall and all its derivatives. Highly effective for ADHD. For OCD, where we do have more data, the data is mixed. Some have suggested that the stimulants can make OCD worse. Some studies have suggested that it can make OCD better. So I think it's equivocal at best, even for OCD. And I'm not familiar with a lot of data for bodily focused repetitive behaviors. Maybe Dr. Grant is.
We looked at a large sample of people recently with hair pulling who were on or not on ADHD, and really didn't find any difference of those people who had stimulant medications. So it doesn't seem in the big picture necessarily to be something that people or parents need to fear about if somebody has ADHD and is put on a stimulant. But I do think, having said that, in the big picture, there are individuals, and many of them over the years, who've told me, wow, when I take something like methylphenidate, I pick more. So on an individual level, those comments are very important. And if that were to happen, then what I always suggest is perhaps then switching to a non-stimulant driven ADHD medication like atomoxetine, which is also called Strattera, or even something like a bupropion, Wellbutrin option, which can help for ADHD too. So sometimes there are other options if the person's like, wow, this seems to make my picking or pulling worse.
Mm-hmm.
We have a lot of questions about NAC, Dr. Grant, and especially related to access to NAC and what particular brands. And we know that access is a challenge right now. We also have several other questions about dosing, which I know you briefly talked about. But if you could just give an overview of kind of where NAC is at, access to brands, dosing, that would be great.
So, so the dosing piece, it's sort of has a short half-life, we'll call it. It's in and out of your body fairly quickly. And so it's best to kind of divide up the dose, breakfast and supper. And I usually start people at 600. It usually comes in a 600 milligram capsule. 1 pill at breakfast, 1 pill at supper. The primary side effect people get is that sometimes it makes them a little nauseated for about 45 minutes after they take it. So if you have some food in your belly, it's often less that way. And after a week, then I have people go to 2 pills in the morning and 2 at supper, which is a total of 1,200 in the morning and 1,200 later in the day. And then give that about 6-ish weeks, 6 to 8 weeks to see if it decreases the overall drive to pick or pull. And when people get some benefit, but maybe not a ton, then they could even go up, as I mentioned, to 3 pills and 3 pills. And could they go higher? No, I mean, we just haven't found any extra benefit at, taking, like 4 or 5 each twice a day or anything. So, so that's kind of the dosing that I recommend to people, but I think it's about the length of time people need to be on it too. Some people after a couple of weeks give up and like, yeah, I can't take it. It's not helping. And I would just say to be somewhat patient. In terms of finding it, I will say, I heard during all of COVID that during that time that Amazon had quit selling it or something, and that they started worrying that maybe it was kind of a pharmaceutical drug. I don't even know what the policies and all of that were. I will say again, I have no stake in any vitamin company. When we did the research, both for our hair pulling study as well as our skin picking study, we had to show our pharmacy that the company that wherever we bought it from had real chemistries, that they could actually show us this is real. It really is N-acetylcysteine in this little capsule. And I figured that was the simplest of things. And so I wrote or called or emailed probably 20 companies, and nobody would send that to me. So one company did, and thank goodness it was the cheapest. So that's the company I've been using, and it's Swanson's Vitamins out of Fargo, North Dakota. They're an online vitamin store. I think it's like swansonvitamins.com or something like that. But, you can Google the name. And as far as I know, they're still selling it and sending it to folks if you ask. So I don't know what the status on the Amazon world is. So my apologies for my ignorance on that.
Yeah, and I follow Dr. Grant's lead. I usually recommend the Swanson since it's the formulation that was in the clinical trials. So ain't broke, don't fix it has really been my approach there. And I also dose the same way, 600 for a week, twice a day, and then 1,200, give that some time. And then if need be, go up to 1,800 twice a day.
There's a follow-up question as to whether that dosage is for adults or for kids. There's a question specific to a 13-year-old and dosage for NAC.
Well, so the study that looked at NAC in children and adolescents did do the same dosing. So, and it wasn't beneficial. Well, I should say it didn't separate from the placebo. Everybody kind of got better, and we don't really know why necessarily. Is hair pulling different in kids and adolescents? Maybe. It's hard to say, but the dosing was the same and kids didn't have any issues with it. So it doesn't seem to have any negative effects in say, a 13-year-old, for example.
Yeah.
Okay, we've got a lot of questions coming in. We have some questions related to clinical trials, several questions related to clinical trials. Are any upcoming related to TRIC or SPD?
I guess I will say that other than, again, I had mentioned that we have this cannabidiol study, and we are planning another study to start soon. You know, I'm not aware of other centers that are doing things. In part, they cost a fair bit of money, there's no drug company sponsored studies. I'm not aware of anybody currently interested in it from a large company perspective. So we don't have anything like that sort of in the works that would be one of those studies that everybody in the country takes part in. So I think it's basically if a small center may have one. But again, if people are interested, clinicaltrials.gov, you can type in trichotillomania or skin picking disorder, and they will let you know what has been done. You know, if it was done 20 years ago, but they'll also tell you if there's a little code that says recruiting, and they'll tell you also if there's anything going on in anybody's neck of the woods.
Yeah, I concur. I'm not familiar with anything other than the studies that Jon is doing currently.
Okay, thank you. The next question is there a relationship between PMS, PMDD, and BFRBs in terms of BFRBs getting worse around menstruation time?
Yes, there is. And you don't necessarily have to have one of those diagnoses for it to affect your hair pulling or skin picking. But in many patients, they do describe worsening of bodily focus repetitive behaviors during the menstrual cycle. Also, we've always wondered, given that the predominantly females have reported bodily focus repetitive behaviors, if these female hormones were involved. On the other hand, Dr. Grant and I did just published a community-based study of over 10,000 people, and we found for the first time in a really large sample that looked at everybody that actually BFRBs were about 50-50 between male and females. So we don't know if hormones are involved in the etiology of the disorder, given that it's 50-50, but we do, I think Dr. Grant will echo this, we do see patients where during their menstrual cycle, their symptoms are worse.
Yep. I think there's still so much we have to understand about hormones in mental health, quite frankly, across the board. You know, some women have told me too that even say during pregnancy, their BFRB got a lot better. And is that just because there are other, distractions and, I don't know if it's that simple, or is it, again, one sort of wants to understand on a hormonal level the complexity of our interactions between mental health issues and these. It's just, it's been more elusive, I think, in the BFRB world.
Okay, the next question is related to inositol. The participant has said they've had success using inositol, but what do we know about that supplement and its efficacy with BFRBs?
First studied in OCD many moons ago, boy, long time ago. And the idea is inositol is a very important part of the membranes of neurons. And the idea is that it's increasing integrity of the membrane of the neuron, and that's a good thing. And that's basically the general gist behind it. There was some data to support its use in OCD. And then what often happens if it's helpful for OCD, people look at it in OCD-related disorders. I'm not familiar with data in bodily focused repetitive behaviors, but it could potentially be helpful. Jon may know better than I. I will say you have to take an awful lot of it. It's a powder form, So yeah. Go ahead, Jon.
So, Fred Penzel has written about it in his book, The Hair Pulling Problem. And has suggested it to people for decades, and I respect that. And I think much like the question, a lot of people have said it really seems to help them. We did a double-blind study looking at inositol plus a powder that was just an inert, nothing powder. And it didn't separate from placebo, meaning it wasn't better than taking nothing. Now, so what do we do with that information? Do we say it's not useful? Well, clearly, the testimonial evidence suggests that at least for some people, it is. And so when you do these studies, you're just looking at the means, right? Kind of a group and a mean. And so I think the next step would be to figure out, much like we've done with naltrexone or something, is there a subgroup of people who might respond really well to inositol, whereas somebody else doesn't? And we don't know that. And when we did our study, for example, and you only have like 50 some people, you don't really have enough people in a study to sort of parse all of that on a granular level to sort of see necessarily. But I think that might be the next step, because, over the years, people have told me yay, and other people have told me nay, and I've never been able to really figure out the difference.
Yeah, not to go to stray a lot, but that's one of the reasons we did the BPMI, the Precision Medicine Initiative. Is all of the trials we've described thus far were take all comers with bodily focus repetitive behaviors. And the idea of that initiative was to see if we could identify subtypes and not treat everybody one size fits all. But once we identify those subtypes, see if some subtypes respond to X more than Y, and another one would respond Y more than X. So we're also hoping to really move more towards precision medicine instead of the one size fits all approach. So that'll be interesting in the coming years.
Thank you. Next question is related to thyroid. Are there any connections between low thyroid function and BFRBs?
Not that I'm aware of.
Not that I'm aware of. It's a good question.
It's a great question, because we know it plays a role in depression, for example. But yeah, it's a great question, but I don't know of any studies of that.
Okay. Next question, thoughts on Abilify regarding its efficacy with skin picking disorder for children age 10?
Want me to start on that one as well?
Why not?
Yeah. So Abilify is one of the atypical antipsychotics that I talked about earlier that blocks dopamine receptors. Some of them have more data than others, but at the end of the day, we typically will use any one of them. Abilify differs from many of the other atypical antipsychotics in that it's usually not, you never say never, but usually not sedating. If anything, it could be a little activating. That can be really good in somebody who's shut down and depressed. If somebody's really anxious, activating them might not be a great idea. The other side effect of many of the atypical antipsychotics is what we call metabolic syndrome, where people gain weight, their cholesterol levels may go up, they may experience insulin resistance, sometimes to the point of even developing diabetes. Abilify is not immune to that, but it's less likely to happen compared to some of the older ones like Zyprexa, where everybody gains weight. So, so those are kind of, if you look at this, given that it blocks the D2 receptor, looking at the side effect profile, those are kind of the pros and cons of Abilify versus the others in my mind.
And I would say that the only data, the Zyprexa or olanzapine, was done in one of those fancy double-blind studies with a placebo. The Abilify or aripiprazole was done from some folks at Stanford, probably now about 15 years ago, but it was only what we referred to as that open label study, meaning about a dozen people came in and they were adults and they all got the medication and they seemed to do well. So that was lovely, but would they have done well, on a lot of things? Was there something else driving their improvement? It's always hard to say. And we don't have these studies in children. And so I also caution, because as Darin mentioned, this metabolic syndrome with the potential for diabetes, that if one is thinking about one of the atypical antipsychotics, just to make sure that some of the maybe easier options have been tried, like the NAC or clomipramine or behavior therapy. Still, even though we're talking about medication here, the lion's share of the data would still suggest perhaps trying some form of behavior therapy first to see. And then you kind of have to balance risks and possible benefits, right, as you kind of move along.
Thank you. We have a question related to NAC being combined with an SSRI. Can you share more about that, please?
It's safe.
Yeah.
Yeah, it can be combined with no difficulties. I think in the world of OCD, the augmentation, when they were referred to as adding on something, they actually looked at NAC added on to an SSRI in the case, in a few studies in OCD. Some found good benefit, others found no benefit or something in between, right? I mean, as most studies will show, but it was safe in all instances. So it can be added on to an SSRI.
Yeah, easily. And since we got back to the SSRIs, I want to emphasize one other thing about them. The trials for bodily focused repetitive behaviors alone were equivocal, I talked about. But you also, when you think about medications that you're adding for patients, you also have to think about things other than the bodily focused repetitive behavior that they're experiencing. And I still use SSRIs a lot because the SSRIs are very helpful for mood and anxiety. And often patients will have bodily focused repetitive behavior patients will have either some mood or anxiety issues. And the SSRI can certainly help with that. And if you help with comorbid issues, it may make it easier to treat the bodily focused repetitive behavior.
Yep.
So that's kind of the pros and cons of the SSRIs, is they may or may not work for the behavior, but they can be pretty effective for anything that's going on in addition to the behaviors.
And for people, again, who may not have even responded to the SSRIs, the clomipramine is, at least in my opinion, a little bit more useful. And so even for the depression side, it can be good for depression and anxiety plus the BFRB. It does come with more side effects, like some constipation and some dry mouth. But so I agree. I think that those co-occurring issues become important. I also should tell people, and maybe people aren't going to be surprised, but, when you go and you hear about like a drug for, high cholesterol, something like a Lipitor, it's been done in thousands of people, right? I mean, literally tens of thousands of people by the time it makes it to market. The SSRI trials in BFRBs were done in about 20 people, 15 people in this study, 12 people. It's, so you can already tell kind of on its face, it's good data and the researchers were brilliant, don't get me wrong, but it's sort of just kind of apples and oranges sometimes when we sort of thoroughly say yay or nay to a medication in the BFRB world. We just do it with a lot less sort of evidence.
Thank you. We have a participant who's wondering, is there any research related to antihistamines helping with itch blocking for people with BFRBs?
I'm going to turf that to Jon because my answer is I'm not familiar with any, and I'm wondering if he is.
No, I'm not aware of any research on it, but I recently was at this large dermatology conference. And I must say, God love the dermatologists. They've become, and they've always been very interested, particularly in skin picking. And so, and sometimes the itch is even more pronounced there, this kind of tactile feeling like something is kind of odd about my skin here. And so that's where I gravitate, say, to pick at it. And they've used topical creams to get rid of itch. They've used any number of things. And so again, just a lot of case reports, but if itch is at least a trigger, maybe that is something to look at, or at least have sort of dermatology also involved to find out if there's anything actually sort of different that can be done even in terms of skin sensations. So,
And it's pretty low risk. I mean, that's
Yeah.
the other advantage. I mean,
Yep.
when we talk about risk benefit, that's a pretty good one.
Okay, we have a participant who's interested in hearing a little bit more about Wellbutrin and Cymbalta in supporting people with BFRBs.
Yeah, I would suggest the data. We don't have any data to suggest that Wellbutrin would be effective. It is a dopamine drug, but it does the opposite of what the atypical antipsychotics do. So the atypical antipsychotics block dopamine. Wellbutrin kind of potentiates dopamine. So I don't think we have much data, but I'm also not terribly optimistic about Wellbutrin for bodily focused repetitive behaviors. It could be helpful for depression and sometimes for ADHD, but not for BFRBs. Cymbalta is in a class of drugs called the SNRIs. So the SSRI stands for selective serotonin reuptake inhibitors. The SNRIs are serotonin norepinephrine reuptake inhibitors. So it blocks not just serotonin, but serotonin and norepinephrine. Most of those drugs appear to be effective for the same things that SSRIs are effective for. The big question is we don't know what the N buys us. If you suspect that something would respond to an SSRI, there's a good chance it would, that in a population at least, it would be responsive to an SNRI as well. But we don't know what the N is buying us, what the norepinephrine reuptake inhibition is buying us.
Thank you. We have a parent writing in with a specific question. My daughter takes 80 milligrams of fluoxetine for OCD, and it helps with obsessive intrusive thoughts, but it doesn't seem to touch her BFRBs, possibly even makes them worse and more likely to engage in those behaviors. Any thoughts or input on this?
I would certainly build on the improvement for the OCD and not bail on that drug if it's helping with that. And the good news, she's taking high dose. We know that you typically need higher doses for OCD. So whereas somebody with depression or anxiety may do well at 20 or 40 milligrams, we like people with OCD to be at 60 or 80 milligrams. So your daughter's at that dose, which is great, and it appears to be helping somewhat with the OCD. So it's half empty, half full. The half full is the OCD is better. The half empty is the bodily focused repetitive behavior is still there. I would keep the Prozac as the foundation drug, but then add on some of the things that Dr. Grant and I have been talking about to see if you can, in addition now, address the bodily focused repetitive behaviors. So maybe NAC, I would probably do that before an atypical. Well, I know I would, but I don't know if they've had a trial of NAC or not, but we talked earlier about how they're safe together. So the hope would be that if you added NAC, that you may be able to get benefit for both disorders.
And I would add that the early trials of SSRIs in hair pulling looked at fluoxetine or Prozac.
Right.
And those are the ones that sort of said, look, it didn't really, so it's not surprising. Now, could it worsen the pulling as the question sort of suggests? Maybe. I mean, I always say anything is possible, although sometimes, life is sort of unfortunately a bit like whack-a-mole, right? You knock one thing down and something else pops up. And so maybe as the OCD simply got better and there was less mental sort of headspace needing to think about obsessions, that somehow, that's when, the hair pulling kind of surged, which is not uncommon when people have these kind of co-occurring problems. So I think, yes, I agree. I would, instead of getting rid of it, though, for fear that it may be making it worse, adding something like the NAC might be beneficial.
The next couple questions are going to be from parents writing in with some questions. The next one is, my 17-year-old teen has been battling nail biting since age 3 or 4, then trick since about age 10. She's currently on Zoloft now to 200 milligrams. Her trick is out of control. She's wearing a wig. We've been through many therapists, but some who are not familiar with BFRBs. What else can we do to help?
Well, I'll start. I think I'd do the same thing as the case before that was on high dose Prozac. The 200 milligrams of Zoloft is roughly equivalent to the 80 milligrams of Prozac before. You could argue if there's no benefit to stop the Zoloft. However, sometimes you find when you go off of a medication, it actually was doing something. So at the risk of piling on, I would probably leave the Zoloft on board, but then try again something like the NAC to see if that helps with the hair pulling.
I think yeah, I agree. I mean, I appreciate the question and the distress of the family about this. Again, I don't want to sound like a bit of a broken record, but we really, at this point, based on evidence, have a handful of options. When you think about depression, there are, 40 antidepressants available or some, such number. And so I think that we are sort of sometimes fighting a bit of an uphill battle. And so I think one thing that parents and people who struggle need to know is it's in some fundamental way really not them. It's really still the lack of science. It's kind of, we definitely need more on that front, and more of a concerted effort to understand all of these issues. But you guys probably all know that. And I'm sort of preaching to the choir a little bit, but I hear this a lot, that people continue to struggle. And we can know so much about BFRBs, and yet we don't have these amazing options that boom, that we can guarantee 98% of people will get better on something. And it's still a bit trial and error.
Thank you, Dr. Grant and Dr. Dougherty. The next question is about skin picking prevalence, and it sounds like it's related to BPM and what's been identified with subtypes. So here's the question: do you know which markers are prevalent with skin picking? Does it do any good to know if we are high in any of those marker areas?
So I will say that when Darin mentioned the prevalence study that we did for trick in this large 10,000, we also looked at skin picking. And we did find, that just from that, about a little over 2% of folks had skin picking, maybe smidgen more common than hair pulling. And it does speak to, the fact that this is why we're so thankful that the DSM-5 recognized it, because it clearly is a very common problem for people. When we are looking at subtypes, we don't have, like, say, biomarkers yet or clear markers of subtyping at this point, particularly for skin picking. And so I wish we did. We don't. I'll let Darin add in, his thoughts on answering this too.
Yeah, I think the BPM has really been the first pass effect to try to look for subtypes. And what we've looked at thus far is mostly behaviors and experiences. So, what type of behaviors you do, and also experiences, how much anxiety or impulsivity, et cetera. And we've identified some putative, meaning kind of beginning. We can always remold them as we get more information, subtypes. But that's where we are right now. And we think it's important to do so because we talked earlier about trying to find something that's not a one size fits all. But we have not trialed any of those subtypes for interventions yet. That would be kind of the next step.
Yeah.
Thank you. Here's another question from our participant. I have had trichotillomania and dermatillomania since age 7 and 14, respectively. I now have a son who is 2.5. Since around a year old, he started touching his hair, mainly when he is having a bottle or sleepy. I've not seen him pull hair out, but he does occasionally make those movements. Other than redirection and distraction, is there anything else you recommend to help him at this age?
I certainly wouldn't start medications at 2 years old. I would, kind of watch and wait and see what happens. I think redirection can be helpful as long as it's not too frustrating to the child. But yeah, I think watch and wait. Certainly don't be starting any medications at 2 years old.
There are lots of behaviors. Yes, I mean, I agree. I There's some of our data has shown that in folks with BFRBs, it's very common that another family member, about 1 out of 4 people will have another family member who has a BFRB. Not everybody, about 25%. So it doesn't mean that somebody's child will struggle as well. But I think, as I try to tell parents that watching, as the child develops and seeing if it does develop into a problem, I mean, by talking about it as early as the child may be able to at some age, can maybe help sort of alleviate or eliminate some of that shame that people often have about the behavior when they've done it in private for years, even when their parents don't know. So I think sometimes parents who have BFRBs can be wonderfully positioned that if their child does struggle, which one never knows, if they're going to or not at 2, but if they do, that will be the parent can be an amazing resource for the child, to recognize that, this is a behavior and that there's help. So.
Okay, we've got time for a couple more questions. This one's related to probiotics. Would love to hear anything you know that's promising in terms of probiotics or treatments acting on the gut microbiome, and whether you think that connects to the role of serotonin in the gut or a different mechanism.
Yeah, that's a great question. And that's a huge question across medicine. And in particular for mental health, is our microbiome is very important for how much inflammation we experience. We believe that inflammation can be part of the causes of some of the psychiatric disorders. I don't think we're sure for bodily focused repetitive behaviors, but certainly there are cases of kids with infections developing OCD. And we also believe that inflammation is involved with depression. So the microbiome, which you can affect with probiotics, certainly has a role in inflammation. And then you bring up something else that's really important. I don't know if this is true or not, because I'm not a gut guy, but apparently there are more serotonin neurons in the gut than there are in the brain. So there might be an effect there. I would say it's early days in terms of probiotics for mental health in general, and as always, BFRBs are a little bit behind. But it's an area of inquiry that we're going to see, I believe, explode. So we don't have the answers yet, but that's on the radar screen for certain. And again, the risk-benefit ratio is pretty good, right? I mean, probiotics are probably good for you anyway. And if you get the added benefit of it helping with the BFRB, then that's a win.
Thank you. And this is our last question. Comes in saying, thank you, Dr. Grant and Dr. Dougherty, for all of your work on these studies and research. Where can we find your research, studies, trials, and more information about the drugs that you've mentioned?
For our research, there's a website called PubMed. You can just Google it, and then if you enter our names in there, it'll bring up all of our publications. And I'll let Dr. Grant close with talking about resources for where all the medication stuff is kind of aggregated.
So we do have some of the medications are on the BFRB.org website. We have done a sort of summary of medications used in BFRBs as a starting point. And I think if you read through that and have more detailed questions about it, you can always, as Darin mentioned, go to PubMed. And if you want to sort of get through the scientific articles. And for ongoing things, as I mentioned, clinicaltrials.gov is a good place to see if there's either a behavior therapy trial or a medication trial for BFRBs anywhere near you. So if people want to participate in clinical trials, that's also an option, or at least to find out where things might be moving.
Thank you. This hour went very fast.
It did.
We had a lot of fantastic questions from our community and a lot of amazing answers from you both. So on behalf of TLC, I would like to thank you, Dr. Grant and Dr. Dougherty, for making time today to be here, for your willingness to answer questions. for your continued work. Like you said, Dr. Grant, this is a labor of love on behalf of this community. We thank you so very much for all that you do to make a difference in the lives of so many.
Thank you. It's always a delight.
Yes, thank you. And good. Thanks everybody for joining. I hope you found it helpful.
I wanted to thank the amazing TLC staff for putting this event on today, and to all of you for being here together in community. Thank you. Don't forget to help us by completing the post-event survey, which is now linked in the chat. Completing a post-event survey enters you into a drawing for a BFRB Brave box valued at over $150. You won't want to miss that. Get registered now for more BFRB Awareness Week events. There's a little something for everyone. You can learn more on TLC's event page, and that link is now in the chat. And it's not too late to wear your BFRB pride. Order your BFRB merch today through Bonfire, and remember that 10% of every sale is donated back to TLC to support programs like this. And the link to our BFRB Brave merch is now in the chat. And finally, if you enjoyed attending today and learning more from our experts, please consider supporting TLC by making a donation. This helps us continue to offer programming like this and BFRB Awareness Week and more. You can make a donation now at bfrb.org/donate. Thank you again for joining us. We wish you a very happy BFRB Awareness Week and look forward to seeing you all again soon. Have a great day. Bye-bye.